My name is Bankole Johnson, and I'm at Casa Privé in Brickell, Miami. And we have a regenerative center in Brickell, Miami. But I'll tell you a little bit about myself. First of all, I'm a medical doctor. I qualified at the University of Glasgow. I have a doctorate degree in neuropsychopharmacology and neuroscience, which I did at the University of Oxford. And I have a doctoral science degree in that I actually received working between Glasgow and Oxford University in molecular genetics. And I've got a master's of philosophy, which is my small degree in computational mathematics. So a lot of this is going to start off at a very basic level because I've been asked to do basically a PDPA 101 because I understand that some people here are obviously great experts and they might be bored and go to sleep. But to make sure that everybody who comes to this actually gets something out of it. So I'm going to do something fairly basic to start off with, then I'm going to present some clinical findings for us. So let's do the first slide. Okay. So the first slide tells you a little bit about mesenchymal stem cells. And mesenchymal stem cells have been around for quite a long time. And in fact, even though it's not on this slide, I do talk a lot out of the slide just because university professors do things like that. And the earliest use of mesenchymal stem cells, or the idea of mesenchymal stem cells, was in the 16th century in China. And it came over to Europe around about 1910 by a guy called Davis, who was using placental extracts to heal skin lesions using skin grafts from the placenta. So that's how we got here. And then it took almost another 70 or 80 years before anybody started injecting this material into anyone. My exosomes are byproducts of mesenchymal stem cells, and they're useful because one of the important, interesting things about them is their small particulate size. And that's going to become important when we start to talk about where you're actually injecting these products. So the size may not make a difference if you're injecting into a knee or a shoulder, but if you're injecting into a spine and you're trying to get into the brain, they are extremely huge and they will not go past the blood-brain barrier. So what are regenerative protein arrays? I actually call them PDPA, so I'll apologize for calling them PDPA or RPA. The most important thing to remember about them is they are composed of three basic items. They're consisting of proteins, growth factors, and other molecules. So basic science. I'm sorry if you want to go to sleep, you can go to sleep now, but I'll just give you a little bit of basic science. The proteins that are contained are usually things like collagen, which is a vital building block, as you know, for proteins. They also contain a matrix, and these are metalloproteinases, and they're called MMPs. These are enzymes that actually scavenge and help to repair damaged muscle tissue. They contain proteoglycans, and they're also called glycosaminoglycans. They also contain adhesion molecules, and adhesion molecules are important because if you're injecting RPA and or PDPA, it's important. These adhesion molecules are very important because they actually help to stick it to where you're actually trying to inject it. The growth factors that are contained, there are only three of them to remember, so it's getting simpler now. There are only three to remember. The first one to remember is something called vascular endothelial growth factor, which is what actually helps to create blood vessels. The second is fibroblast growth factor, which helps to produce the scaffolding for the skin, the bones, the muscle, the cartilage. And then there's a third, which is called transforming growth factor, which helps to modulate and remodel areas and is particularly important for inflammation. Now, if you're still with me with this, I will tell you why this is important. As Joe said, these RPAs are not cells themselves, they're products of cells. And the importance of them is that they actually produce cell signaling. And so I'm going to go to the second next slide, and I'm going to talk a little bit about cell signaling. I don't know whether we have it on here. Well, I'm not going to, there's nothing on there that I want to get. Okay, I'm going to do this with cell signaling. So why is cell signaling important? So I'm going to take you through a little bit of molecular genetics, just a tiny little bit, so you understand what happens. Micro DNA is actually the main signaling molecule that is used that is a part of RPAs or PDPAs. MicroRNA consists about 20 to 24 nucleotides, and it's basically transcribed from DNA. When DNA produces um, microRNA, it actually produces first something called a pre-microRNA or pre-miRNA. This is in the nucleus, but it has to get to the cytoplasm. So in the nucleus, what has happened, it is reduced by an enzyme, and I like this, it's sort of a Russian-sounding name, drosha. So this enzyme reduces the size of the pre-mRNA, then it's exported into the cytoplasm by something called exportin 5. When it gets into the cytoplasm, it is then modified or modulated by another enzyme called DICER. All these fancy names in molecular genetics. And what that does is it helps to create a mature double-stranded microRNA. One of those strands of the microRNA is then attaches itself to a complex called the RNA-induced silencing complex, or RISC, as a better word. And this combination is what, when attaches to mRNA, produces the signaling. And how does it do this? It produces it through a process called gene silencing. Gene silencing is twofold. One is called perfect complementary gene sequencing, and the other one is partial. When it is perfect, the mRNA is completely degraded and destroyed. When it is partial, it is basically modifying the mRNA. And what does mRNA do? We all know what mRNA does. It helps reduce protein. It helps to regulate gene expression. This leads to cell differentiation. It leads to apoptosis or programmed cell death. Now, why is this important? Because if you look at the cells of individuals who have cancer or who have neurodegenerative disorders, they have dysregulated messenger RNA, microRNA, so they're dysregulated. And you can actually use miRNA as a biomarker. Also importantly, they control the immune response. And this is probably why when you inject RPA into individuals, they don't immediately have a strong immune reaction, because this actually suppresses it. And it's actually very useful if you were going to be involved in organ transplantation or other things. Now, I won't go into all the bits of RNA, but there's several types of RNA, and I'll tell you, but there are very different ways in which cells actually talk with one another. Now, in terms of cell signaling, probably most of you want to know what cell signaling is about. So cell signaling can happen either by messages being transported across the synaptic cleft. It can occur by hormonal means. It can also occur by something called pancreas stimulation or cell signaling. So there are various ways in which cells talk to each other. Obviously, if a cell comes in direct contact with another cell, it can actually send messages. One of my teachers at Oxford used to say to me, the important thing and the interesting thing about all of this is, if you think about even nerve cells, and most of us probably think of nerve cells because we went to medical school, we look at we look at neuronal cells, for example, and you look at the nucleus of such a molecule of a neuronal cell, and then you look at the dendrite. And the idea here is, my props is you to say, remember that to that cell, sending signals is just like sending someone on a 5-mile run. So it's a long way. These signals go a long way. And that is why they're actually effective in being able to work by even by injecting them IV, etc. So that's the basics, if you like, of what RPA or PDPA is, and we'll get into some other things. But the next slide says, what kind of doctor are you? Now, I was obviously trained as a very conservative doctor who, wrote several hundred papers and all of that, and did FDA trials, built up a little pharma company that went all the way to phase 3 and is on the NASDAQ, that kind of thing. That is traditional conservative medicine. And it has its place, but it is not, if you want to wait for a cure for 30 years, that's the place you need to be, okay? If you want to do something more interesting and be progressive, then you need to be able to assess and ascertain things that are coming up in the literature, see whether they can be tested. But remember, when you're doing that, you are yourself conducting research because there isn't that much known. And we don't, for example, I don't know any phase 3 large-scale clinical trials on RPA. So you're basically doing an experiment. And in an experiment, and one of the important things about forums like this is we're collecting data, we're collecting knowledge, and we're educating each other to be able to refine a new specialty. Now, the FDA classifies these as cell factors. And to me, a cell factor is like calling something a nutraceutical, but that's fine. I'm happy to take whatever they want to call it so long as they let us continue to use it. Next slide, please. So how are RPAs actually formed? Now, if I took you to my lab when I was at the University of Maryland, we can actually make RPA, and you can actually make RPA yourselves. But Nova makes a great product, so I'm not suggesting you go and find placentas yourself and actually try and make RPA. But basically, it's a process by which you can actually harvest placental tissue, which is usually discarded as medical waste. And you need to be able to get not only the whole placenta, but also the membrane of the placenta and the arterial feeds to the placenta. Because what you need to do is you need to put them into a bioreactor. You need to stimulate all the layers, including the trophoblastic layer, to make miRNA and the growth factors and the cytokines. The cytokines I decided I was going to talk about a little later. The reason why I didn't talk about it initially is because cytokines are a little bit controversial in medicine. As most of you know, there are pro-inflammatory and there are anti-inflammatory cytokines. And one of the cytokines that is actually produced by RPA is something called tumor necrosis factor, or TNF alpha. And TNF alpha is actually is usually seen in inflammation. It's actually a cause of inflammation. But when it is with the interleukins that are actually produced by RPA, it seems to have a different effect, which is a modulating effect on cell signaling and cell growth. So once the RPA is produced, then it is processed, and then it is sent off to all of us by Nova. Next slide, please. So one of the questions I think Dr. Shah raised earlier was about the inconsistency of using exosomes and perhaps MSC. The reason is that it's not easy to categorize because of the size of the exosomes and the work that's been done on the exosomes, really the expression levels that are being produced by the miRNA. And therefore, the response is inconsistent. We have had patients where we've given half a vial to, and it's like magic. There are others in which we probably need several syringes of the stuff. So it's inconsistent. One of the advantages of RPA is because the age of the donor is usually fairly circumscribed. People who have over 50 do not usually give birth to children, for example. And the gestational age of the placenta is usually constant. And because of that, that product tends to be fairly stable, and actually the effects tend to be measurable. So through a process of multi-stage filtration, all the other cellular components are removed, and the final product is endotoxin tested to just reduce an immune reaction. Now, an immune reaction, even from native placenta products, is actually pretty low, but it's good that they do this anyway. There are other proprietary regulatory things that are important for a proprietary product, but I'll let Joe deal with that because that seems to be a secret for Novo. But let me give you an idea. Now, Novus is pretty conservative in their slide, and I'll show you one of their slides in that they say they have about 80 to 81 microRNA different types of microRNA messenger systems. I actually think it's probably a lot higher. And the reason why it's a lot higher is because of the effects on the different organs. So, for example, I'll show you a slide which shows effects on the heart. It shows effects on the bone. It shows effect on cartilage. It shows effect on a wide variety of expression modules. And when, I had my own lab at the University of Maryland, this would result in about 400 to 450 expression signals. So I think they're being fairly conservative. Next slide, please. I want to answer another question that Dr. Shah um, proposed. And he said, well, he had this athlete, and this athlete, they were using exosomes and some stem cells, and he doesn't want to be changed over to RPA because it wasn't something that he was used to, and he just wanted the old stuff. Let me give you a good answer. One of the interesting things about RPA, which a lot of clinicians may or may not be aware of at a molecular level, is it forms, if you like, a matrix or a scaffold. And that matrix and a scaffold potentiates the effects of the stem cells and the exosomes. So when you give a combination of RPA and stem cells or exosomes, you're actually magnifying the messenger or the expression results. Really is a very large amplification. I can't tell you because I'm not measuring it in a lab, but it could be as much as 3 to 5 times the effect. This slide shows you, it's pretty small for me. I can barely read it because of my age, but it's showing basically various levels of signaling that is going from Genesis PDPA, Wharton's jelly. If you don't know what Wharton's jelly is a gelatinous substance around the the placenta. It also contains usually parts of the umbilical arteries and cord, and it slightly different from is different from PDPA because it contains chondroitin and hyaluronic acid and a high concentration of MSC. Then there's the amnion itself. There's PRP. PRP is a good vehicle, if you like, because it helps to also create the scaffolding effect. And in our clinic, I sometimes add a little bit of PRP to create the scaffold. And then it shows you here for the bone marrow and the cord blood. I wouldn't suggest trying to get anything out of cord blood to do anything because truly there isn't very much in terms of signaling in cord blood per se. But this is very impressive. You can see a lot of the signaling that is going on with PDPA or RPA. Next slide, please. So here is a histogram which shows some of the differential effects between the complete product of RPA and Wharton's jelly, the amniotic fluid, the PRP, bone marrow, and cord blood. One of the interesting things that I always get asked is, Doc, why don't we just drill into the patient's pelvic bone, get out the patient's 60 or 70-year-old stem cells and give it back to them. All right. So the idea is most people don't like that in our clinic. It's pretty painful. And the harvesting can be quite complicated depending on how good you are. There's some physicians and clinicians and orthopods who are extremely good at doing this, but general docs are usually not very good at doing this, and therefore the results are very variable. So I think providing that you are obtaining from the market is actually a much better way of doing it. And I actually think the results are legions better than actually using the person's own stem cells or products. Um, Next slide, please. Okay, this is a slide on the RPA's mechanism of action, and I've already talked a little bit about that, but I would like to emphasize some of this a little bit more. Okay, so what are the effects that we're actually interested in as clinicians working in regenerative medicine? What we want to do is to accelerate wound healing for most of us. We want to reduce inflammation. We want to reduce immunity or create immune tolerance. This is very important, especially if you're treating some other diseases. And I can talk about some of our experience treating diseases like Lyme disease and also diseases like CLAD, which immune tolerance is very, very important. Skin rejuvenation, chronic wound healing, cartilage repair, and something that I think is very exciting indeed is neurological diseases. RPA, and I'll show you one of our patients, has been really very helpful in our treatments of patients with both neuropathy, so with neuropathy and or both Parkinson's disease. We are about to try it for Alzheimer's disease, and we also are beginning to try it for individuals with mental diseases, or if you like, mental disorders. Why does this make any sense, rather than just injecting RPA into everybody? One of the important things about all neuropsychiatric diseases is that they all produce some degree of brain inflammation. The most common are addictive processes, which activate toll-like receptors to produce a high degree of brain inflammation. And others include diseases like depression, anxiety, obsessive compulsive disorder, also associated with a high degree of brain inflammation. And therefore, because these are measurable, we use the RPA in adjunct to other traditional treatments to be able to produce a much quicker effect. The other piece that I can tell you is we've used RPA on one gentleman who was on the brink of going to the NFL, I believe, and he had a type of myocarditis. It was very interesting. He didn't have cardiomegaly, but he had myocarditis. It had been going on for a long time, and we were able to get his EKG to become more stable because for the NFL, they run all these tests, and usually there are various types of stress EKGs, such that he was able to be at the NFL. I tell him if he manages to make it to the Super Bowl, I want a front seat for actually saving his career. So we will see whether that happens. I know he's not in the current Super Bowl. The other part of this that I want to tell you is that there are certain types of organ failure that I think RPAs are particularly useful for. I've talked about the heart in terms of the myocarditis, heart failure. This is being currently investigated by several clinical trials. Also, kidney failure is a very important way in which you can use RPA to reduce the level of kidney failure. Now, I'm looking to see whether somebody's actually tried this in an overt way for the treatment of pancreatitis or diabetic types of disorders. But I think that that is something that maybe in the questions somebody will produce or provide some answers to. So next slide, please.
Dr. Johnson, if you don't mind me throwing out a question from Dr. Donahue. Um, Dr. Donahue was asking, in your opinion, since this product RPA is considered a cell factor and is handled like the nutraceuticals by the FDA, do you feel that it is mandatory if you use this product instead of stem cells and exosomes to have malpractice insurance addressing stem cell exosome regenerative medicine products, or do you feel that it wouldn't be necessary?
Fantastic question. I think that one of the advantages of RPA that I believe over of stem cells and exosomes is is you can't really get into trouble. It's like giving a nutraceutical. I mean, no one's going to really criticize you for doing that. And so because of that, I think that if you are squeamish about, getting an FDA warning letter, which I suspect with the new regime, it might be you might not get one at all ever because there'll be nobody working in the FDA. Then what might happen is so you might want to use RPA. And yes, I think that RPA can substitute for them, but I still think that in our clinical practice, being able to combine it with MSC is much more beneficial in terms of the outcomes that we have seen.
Well, Dr. Johnson, as far as specifically the need for additional malpractice insurance for regenerative medicine, and Dr. Donahue, I can directly address this too because Novo and Genesis Regenerative also have to have um, professional liability insurance and the likes. And I can tell you plain as day the trigger for us having to have more extensive insurances was involvement with stem cells and exosomes. It was not RPA since it's considered a nutraceutical. So hopefully that helps answer your question. Thank you, Dr. Johnson. I appreciate it.
No problem. Next slide, please. So I think I whizzed through a lot of this in my conversation. As I said, one of the problems with professors, they don't follow slide shows, which is interesting. But we've gone through most of the uses of this. So we've gone through the use of RPA or PDPA for to fix bones, joints, skin repair, chronic wounds, cartilage, neurological diseases, mental diseases. And there is some interesting research if you really are on the fringe there of looking at things of the use of regenerative medicine products for the treatment of attention deficit hyperactivity disorder and also autism in children. So I suppose again it depends on how brave you are to try this. But a lot of kids who have autism, by the time they get to us, they have no more hope. They are so behaviorally compromised and disturbed that and the parents will want to try anything, to be honest, to actually improve the behavioral control and control the language problems of kids with autism. So next slide, please. So here are some guidelines on what you to expect. And I'll lay it with some of my experience. One of the interesting things with RPA, especially if you're giving it into, if you like, a hot joint, is that sometimes the patients will actually tell you they're feeling better after a few hours, which I don't see that with MSC. They can call you back in the evening and say, gosh, I'm cured, doc. And I say, wait a few weeks, and then we'll see how you do. And usually it takes about a week or two before people start feeling really better. But some people have almost an immediate result, which is actually very good for compliance. The usual follow-up is usually about a couple of weeks after the first injection. Then usually because, microRNA degrades and the growth factor wears out, you can expect that over a month or 2 months' time, most of this, it says here about 50%, but I'd say most of it is actually properly degraded. And if you are maintaining a patient, you probably want to consider your second injection somewhere at about the 8-week mark of bringing patients back in. But you need to also balance that out with the clinical outcome. So if the person has had a good clinical outcome, there is no need to keep injecting them, of course. But if they're still healing, then I would repeat the injection and then wait a further 2 to 4 weeks, right up to the 12-week mark before thinking about doing anything else. Most of our treatments are in the clinic, either in a side room, injecting, various things are very easy. We can do it under ultrasound. We can do it under fluorescence. We can use an arm. So they're pretty easy, all side room. Um, Next slide, please.
Dr. Johnson, may I interject something here, please?
Sure.
So I do want to address something that Dr. Johnson just said in relation to hot joints, but rather switching to a different application, which we're seeing more and more of our clinicians utilizing, and that being an IV push. And no, I'm not speaking about an IV drip because you don't want RPA to sit in a drip bag. A lot of the active ingredients will actually stick to the bag. So we're talking about a 3 to 5 cc IV push. One of the things that we're consistently hearing out of our clinicians across all specialties is exactly what Dr. Johnson just said, the speed of impact to the patient. In particular, we have a couple of clinicians that do very high volume IV pushes, a high volume of patients with IV pushes. And their feedback from the patients has been that they're much happier with RPA because even though, say, exosome pushes were effective out at 8 weeks, 12 weeks, etc., that they felt like they were getting a better value with RPA because they had a systemic impact on the cytokine-based inflammatory responses within their body and the likes within a matter of hours or days. So just wanted to make that point. Thank you, Dr. Johnson.
It's a great point. We also in our clinic have a very modern, probably one of the most modern hyperbaric machines. So that really helps as well. So I'm going to talk about stem cell treatment for Parkinson's disease. And this was actually one of the interesting, if you like, forays into this for us. Now, there are a lot of stem cell treatments, stem cell experiments going on, but this actually was an idea to try and do this with a patient, even though we didn't have phase 3 clinical trials. And I can tell you, Parkinson's disease is extremely disabling, especially for young, fit people. Previously, to get Parkinson's disease is it's really a crisis. I mean, you really need to try and help them to try and do something to get this alleviated. And I'm going to show you a patient of ours that came in. She was a middle-aged woman, and she basically came to us in a wheelchair. She was extremely rigid. She couldn't move her neck at all. She couldn't stand up without falling over. And it was, and we decided to try her first of all with stem cells. We tried it both ways. We tried it through injections into Little's area. We also tried injecting intrathecally, but as you know, only 60% of CSF is actually gets to the brain, and then there's a blood-brain barrier. Even though we were using mannitol, I was really concerned that we weren't actually getting anything into the brain. But we were able to help with a lot of the peripheral neurological symptoms. But it was only when we started to use RPA that we got some improvement in the central symptoms. Now, if you look at the size of the way I like to describe it is if you're thinking about a stem cell injection, and I'll go back to a football pitch analogy again. So if the stem cells the size of a football field, your RPA is basically the size of somebody who dropped a coin or something on that pitch. So it's a lot smaller. So there's much more of a chance that we would be able to do this because it's really 20 to 24 nucleotides rather than even being able to be measured in angstroms. So could we roll that tape after the first one was after about 3 months of 2 or 3 months of treatment, and then the second one is about 5 or 6 months of treatment.
You're gonna have to guide me, sir, because I
Okay.
just labeled them as 1, 2, 3, 4. So
I think 1, 2, 3, 4 would work. So this is somebody who this is like four. So you've started in the other direction, but it doesn't matter. So this is somebody who was wheelchair bound. You can still see there is significant rigidity. And what I will say about this patient is on no other medication, not an any dopamine agonist, nothing, only being treated using regenerative products. Let's see the next one. And then the third one. So I think that is, from somebody who is wheelchair bound, she basically got her life back. And, fine motor skills are some of the skills that are usually lost in Parkinson's disease due to the cogwheel level of rigidity. And you can see that there's an alleviation of a great deal of that type of rigidity in this patient. And next slide, please. And next slide, please. So these are case studies that are from Novo. So these are not my particular patients, but this is a young man who lost his contract and who basically had his cartilage regrown with RPA, and he now has a new contract. So all the best to him. Next slide, please.
one keynote thing, if I can throw this out, Dr. Johnson, is one thing that a number of our physicians have been working with in bone-on-bone patients is the fact that there's some cartilage, minuscule parts of the cartilage, doing a series of HA/RPA treatments not only serves as a scaffolding to keep it in place, but also takes the um, shearing force of the joint off of the RPA to allow it to regrow the cartilage. And
I think that's a good point that you made, Joe. And I say unless you've lost much more, I mean 60 to 70% of your cartilage, or you have torn through your tendons completely, then you need to try RPA. This is what I actually tell our clients that come in, who don't want to have that knee replacement or who don't want to have a joint replacement. And usually we've been very successful. So next slide. So this is of a gentleman who had 15 abdominal gunshot wounds. He was paraplegic and he had rehab. He had also two RPAs, IV treatments, right hip injection, and he did much better. Now, I don't know this patient particularly, but Joe, if you know anything more about this patient, you can comment about this
sure.
patient. What
Absolutely. This, despite the military picture, this gentleman was actually involved and got caught in a crossfire in a robbery. Very, very motivated ex-military gentleman. And one of the biggest things that we wanted to highlight here was this didn't just take him from walking with braces to getting off of all the pain meds, but one of the hallmarks of RPA is its systemic impact. And he denoted not just getting off the pain meds and a greater range of motion, but also a byproduct was significantly improved sexual function.
So I want to spend just 1 second on the sexual function. Last week was the first time we actually, and it wasn't last, it was
Love?
2 weeks ago. Um, Maybe I should call Doug as well.
Hi.
Maybe we should all call him, so maybe that can help.
Where are
So,
you?
Very good.
so we've had a patient who had erectile dysfunction for 5 years. And he came to us, he tried all the usual injections, and we actually injected him with RPA into the corpus cavernosum. And his wife called me the next day to complain about what had I done to her husband because he can't seem to get off her. I'm sorry if I offended anyone. So they're coming back in 2 months' time for us to repeat this. Maybe it was just the excitement of the injection. I don't know. We'll see when he comes back. But
Dr.
that
Johnson, I will say we've had multiple patients and executives in the group that have had the RPA IVs and direct injection. It seems to be a commonality that the wives are saying, no, 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 you go stay at a hotel after a couple days.
So we didn't do a caudal injection though, but maybe the next time we'll do a combination. Next slide, please. So we've treated people with spinal injuries as well, not as high as C2, but this is of a case of an individual with spinal and vascular injury, in which he had two RPA treatments, and he was able to extend his upper body and had full use of it for really 15-minute intervals. What we have done is we have used it to treat lower spinal injuries, especially individuals with herniated discs, significant neuropathy, to get really quite a nice result for them. Next slide, please. So this is a case of a kid with ADHD, and this is a really interesting case. It's not one of our cases, but we are now on our second case of doing this. But these we're doing this in children. So this is of a 21-year-old with severe ADHD, violence, who was injected with RPA and became much more amenable. And then the other was of a patient, well, with female ALS and was actually treated with RPA. I'll say that I talked a little bit about the autoimmune function. There are a lot of autoimmune diseases that we are working on with people with RPA, for example, lupus, and also multiple sclerosis. So I'll probably, if we do this again in 6 months or a year, then I'll let you know what happened to them. Next
Uh,
slide, please.
Dr. Johnson, I'm actually really intimately knowledgeable about this case because this was one of our doctors in LA that called me at 4:30 in the afternoon and said, "Hey Joe, could you get some vials to Maui by tomorrow morning?" So we got the vials over. This is actually a mother and son and a prominent family, and she had not been on the beach for years. And the physician actually had a half vial left over from treating the mother, and she asked if it would help her son, and he just went ahead and did it. And I guess the son is continuing to be much more social and affectionate. Interesting.
Nice. So as we go forward, I mean, one of the things, I see that we're only 3 minutes from the end, and I wanted to allow some time for questions. One of the things that I say with all of this is, we are at a cutting edge of medicine, and Now, there's now a board certification in stem cells, which I have, and regenerative medicine. And I think that being able to document your cases carefully is going to be very important. Now, science doesn't usually advance by case histories, but it has to start in some way. And as you know, the great adage of Parkinson's disease was in the 19th century with Lord Parkinson, opening his window and watching his patients shuffle over cobblestones, creating what we now call the shuffling gait. Okay, so as physicians, observation is very, very important to our armamentarium of clinical treatment. This is a picture of a 43-year-old with a longitudinal rotator cuff tear, and also was injected with RPA intra-articularly and an IV push. And the patient reported to have about a 90% improvement in range of motion and also 100% relief of arthritis. And this is one of the interesting things about, I think, RPA is to be able to use it to help individuals with arthritis. And we don't have time to go into that, but I just want to mention that as a side note. Next slide, please. So one of the things we mentioned at the beginning was the use of RPA for skin diseases. I will say that we have used RPA successfully for skin diseases ranging from acne. This is of a lady with a male with psoriasis, but we also used RPA for hair growth and hair regeneration to great effect. And this was a patient who had severe joint and muscle pain and loved swimming, half a vial of RPA, skin recovery. And this is actually very easy to do skin injections, scalp injections, and this really produces a nice result because if to coin an adage, the patient can actually see the result rather than if you're injecting into another part of their body. Next slide, please. So this is a slide that I think Joe would be better talking about, but there is a reinsurance program coming. There is a multimedia mechanism for building your practice, which is being sponsored by Novo. And this is our clinician network support. And hopefully we'll be able to expand this in the future with even more offerings to all of you. I think that's the end of my presentation. So I thank you
Doc,
all for listening to me.
thank you, Doc. And if you don't mind, I'll do a little expounding there. So everybody that's on the call, understand that this product has been used in the reinsurance industry for roughly 4 years. Tens of thousands of patients have been treated. The program is going national. Very shortly here, we should be getting the first 30 to 50 patients that get sent to our advisory board, et cetera. Basically, they're test firing going from one or two practices from the three major companies that are contracted to splitting that out, test firing, going to 20, 30 practices, and then verifying the flow of information, the process, et cetera. And then that'll be turned on fully. The multimedia marketing is something that we just launched with the turn of the year. Our business partner, DGIQS, has over 100 million prospective patients, complete personal health and financial data. They are a opted-in data company for thousands of hospitals, LinkedIn, Facebook, and we have been able to build a platform that is now kicking in. And to give everyone an idea, we ran a 4-hour one text ad as a final test about a week and a half, 2 weeks ago, and walked away with 197 qualified patients that were interested in learning more in 3 states. And now that we're turning the floodgates on, my hope is Dr. Johnson is smiling from ear to ear or punching me because the staff's too busy within the next week or two. The clinician network support, there's a couple of different things that we have. Whenever you purchase a product, you get unique username and password. The secure side of the Genesis Regenerative website has dosing videos. I know a lot of physicians have told me, Joe, I'm having patients ask me to do IV pushes. I haven't accessed a vein in 20 years. Please help. So we put together a video on that, including the supplies and some tips and tricks. So there's a lot of clinical support on the secure side. And then we also have a Genesis forum, which we're starting to build out our clinical registry that'll be on there. We have a scientific deep dive. Talks like this will all be on there, plus white papers, etc. And the coolest thing about it is all the physicians and clinicians that opt into it are able to email each other in the middle of the day based on different anatomical sections of interest to share tips and tricks or ask about tough cases. And last but not least, we will very definitively be expanding the clinical offerings to high-end diagnostic testing, peptides, NAD plus, etc., to aid the patients from diagnosis to um, full treatment and support.
I'm just answering one of the blogs. So did everybody have fun? Good time?
Yes.
You're
Nobody said,
awesome.
Thank
Dr.
you,
Johnson,
Dr.
you're
Johnson.
awesome.
That was awesome.
Yes, thank you.
all right.
Would it be
You have
possible? Would it be possible to know the vaccination status of the mothers?
Actually, I can go back to that. I'm going to go a little bit deeper into just vaccination status. I got to find the right slide. Right here is the key. Genesis is only manufactured from placentas that have a proven 20-year free history of communicable disease, systemic disease, cancer, and genetic altering RX and um, vaccines. So, yes, these mothers have to be COVID vaccination free for their placentas to qualify.
That is fabulous. Thank you for that.
Of course.
We don't want any mRNA spike proteins.
Exactly. That was the point.
That's a longer story. I'll say if anyone on this forum wants to come and visit us in Miami, in Brickell, and you're on holiday here, you're most welcome.
Well, we're in Orlando. We'd like to come down.
Great,
Absolutely
yeah.
welcome.
I'm in Naples and Orlando, so absolutely.
Well, if my kids go to Disney, I'll hop in to come and see you. How about that?
Please do. We'll take care of you.
All right.
So, is there any refrigeration, like really low refrigeration requirements of the product before use?
Nope. Nope.
No.
It's 100% lyophilized, shelf stable for at the point you actually get the product, somewhere between 9 months and 18 months of shelf life remaining. The only time where any kind of freezer or otherwise would come into play is, let's say you only had, because we have full unit vials and half unit vials, halves being for mild to moderate, fulls being for moderate to severe. If you say only had a full vial and decided you only needed a half to treat a patient, once you've reconstituted the product in either sterile water, sterile saline, bacteriostatic water, or hyaluronic acid, then you can take that other half and store it for up to 28 days in a 0-degree freezer.
Mix it with pure hyaluronic acid, or use that as part of the mix with bacteriostatic water.
We have docs doing both.
So you inject it with 1-to-1 with hyaluronic acid.
Well, keep in mind, it's a powder, and the
Right.
vial can hold 2 cc's. So it's about a 2.5 cc vial, but the most you're going to want to inject, so you can roll it around like is 2 cc's. So we do have physicians that are injecting the hyaluronic acid directly into the powder and mixing it up. And then what I would recommend is to draw the fluid out once you've mixed it up and squirt it right back into the vial to make sure you get any remaining residual powder off to the sides. roll it up and then draw it up in final. A lot of our physicians do half direct inject and half IV. So a lot of times our clinicians will mix it up with 2 of whatever the base they want is. And then once everything's thoroughly mixed, they'll draw up with 2 1 cc syringes, one for the IV push, one for, say, the direct inject, and then reconstitute out of those to whatever they want. Say the joint 3 cc's total and the IV push 5 cc's total. And I do want to throw one other thing out. I don't know. Can you guys see me on camera?
Yes.
Just so you know, for those physicians or clinicians on the call that do not do intrathecals, we've had a number of clinicians ask about treating some of the neuro and cognitive issues without having to do an intrathecal. And here is a intranasal nebulizer that we have some clinicians that are putting the patients in a Trendelenburg and then injecting this deep into the sinus folds, if that's of value.
And what about nebulized?
We have plenty that are nebulizing, yes. The only downside, or what I would recommend, is to use a full mask so that you don't lose the medication.
We tend to inject it into Little's area.
Say that again, please.
We tend to inject into Little's area past the inferior turbinates for the best effect, because you can actually feel it going in, because you can feel, especially if you're injecting a larger amount into the sinuses. So you actually know what you're doing. That's what I'm saying. Nebulizers are good for asthma and things like that, and this stuff is going all out of the mask, because there's a lot of it. But this RP is pretty expensive, and so we're not going to diffuse all of it into the air. So we try to be very specific.
Oh, that's good. So do y'all have any experience with use with ozone or as far as the injection is concerned?
We don't use ozone because we have hyperbaric machines, and we have, hyperbaric machines that go up to 4 atmospheres. And I'm yet to be convinced there's any advantage to ozone that is not on a hyperbaric machine. So we don't tend to use ozone. But if you don't have a hyperbaric machine, then you can actually use ozone.
Dr. Shaw, are you on? Yeah, I want to ask a question of Dr. Shaw. Okay, what about with use on other, like when you use the...
Yeah, I'm on, Casey. Sorry, I was muted.
Dr. Shaw, what's that therapy you do that doesn't have the prolo? Yeah, prolotherapy.
Prolotherapy.
Is it for use with prolotherapy?
I combine these things, and I think of prolotherapy and local ozone, prolozone injections as, analogous. So I'll often combine the therapies, because where there's an actual deficit, I'll put the cellular products. But typically with chronic problems, you have a lot of adhesions, and you need to do some broad field hydrodissecting, or I'll use ozone for that. So that's how I combine the two things.
So you would see using this with that therapy?
Yeah, but for a little different reason. I'm combining it because that small amount of volume isn't going to break up adhesions and scar tissue necessarily. So I'll enhance that just with mechanically squirting some volume into the area, and then you also are getting a little bit of additional regenerative activity because of the injecting. So that's how I combine it. Does that make sense? So it's two different things,
It does.
Like I've done with you guys for like opening up the, the muscles in the hips,
Yeah. So do you find systemic ingestion, like if you did a push on this, that if you did a therapy in an area, which might be prolozone or something like that, if you did a systemic injection, it might be drawn to that area, like you did a push?
I would ask the doctor about that one. I would think that that would signal there, right? That you're saying that it signals quite a distance.
Yes. That the therapy might end up in the area that you treated is what I'm saying. The systemic push.
Yeah, that would end up there, right? You guys agree?
Yes.
Sounds remarkable. And is there a online where you can see the costs, and how does it compare cost wise to exosomes or exosomes, the stem
Yeah,
cell?
favorably, favorably. Yeah, you want to speak to that?
Please do.
So I'll very openly throw out the price. For one vial that is a full vial, it's 2,400. If you buy 5 or more, it's 2,200. If you do a half vial, it is 1,400. If you buy 5 or more, it's 1,300 for a half vial.
And so how does that compare with like are we comparing this directly with exosomes or
Exosomes.
exosomes
Yeah,
and
exosomes. This
just
is going to compare favorably. I think the half vial is going to be better than even the 75 billion exosomes we're using.
really?
Joe and I had that conversation before. Yeah.
Yeah, I missed that part. So sorry.
And the beauty
Oh,
of it is you can reconstitute it and then save some of it. You don't have to even use it all. Use it later. So that's really
And is
huge.
that refrigerated or I'm sorry?
Just regular fridge, right?
so once you
Freezer.
reconstitute it, it needs to be in a standard 0 degree freezer. So like your freezer at home. This does not need to be -20 or -80 because those temperatures will actually fracture the proteins.
And how long will it last like that?
Up to 28 days, but do know it degrades over time, so you're not going to want to you're going to want to use it sooner than later to have the maximum effect. But let's say you had a patient coming in on a Wednesday and a patient coming in on Friday or the following Monday. You could keep the remainder in a 0 degree freezer and utilize the other half.
That's amazing. So Dr. Shaw, have you been down to their clinic and are you going?
No, I will. Yeah, I expect because we just met recently, so um, uh, definitely plan on it. And I already ordered 3 small and 3 full dosages, which arrived today. So I'm going to implement them.
Or are you going to be down here? You could implement it on me.
Yeah, that's what I was saying. I think yeah, exactly. That's what I was thinking of. That I'll just bring it down so you can try it. You may want to get some. Maybe you can get a little advice on the protocol we should try in here.
Yeah, we'd love to hear that.
Hey,
Then
Dr.
we just
Johnson, am I remembering correctly from my time in Florida where your office is at? Is that right near that art district?
It is. Yes, it is. It's near. It's not in. It's my home is closer to it, but it's within, I would say, 7 or 8 minutes car drive.
Okay, so my proposition is we all go and have a Casa Preve day, and then we go to the
okay.
art district by his office and get some of the amazing food that's right there. That would
Great. Well,
That
I'll
sounds
be
good.
in Bonita Springs March 4th through the 15th. So if any time during then you want us to plan something, that would be ideal.
So Heidi and I would like to come down too.
Yeah, that'd be cool.
we will figure
Um,
something out.
okay. All right. Great.
This is very exciting, guys. I really think that it sounds like a lot of advantages over what we thought was great.
I agree. Yeah, that's exactly my impression.
I can honestly say I think the best thing, and obviously Dr. Johnson actually is doing a lot of different and more advanced treatments, but one thing that I get a chance to see is all the doctors across the country, and I think the best thing, since I've been in medicine for 30 years in spine and vascular and neuro, the biggest thing that I love about my job now is hearing all of the physicians and clinicians come back and say, I feel like I can get back to being a healer and treat the whole patient. I don't just have to treat an injury site. I can, because I love talking, especially like, say an orthopedic surgeon that specializes in knees. There's a level of focus and expertise there, but at first, when we brought the product out, there wasn't a lot of discussion about IV treatments. And so I started asking, like, say, the orthopedic surgeons, well, how many of your knee patients is that their only problem? And they'd all laugh and say, zero. Everybody has 3 to 5 things wrong with them. And I think that's been one of the most unique things is all the clinicians like Dr. Johnson and other members on our advisory board that have pushed the envelope, learned a lot more about what RPA can do in a number of different conditions. And now I think the really exciting thing is it allows you guys to get back to being the healers that you went to school and your passion of making people's lives better, but being able to treat the whole patient, not just an injury.
That's good. So, question along those lines. So, the push, the IV push, is that the way you treat, say, a heart or even ED and things along those lines, or do you do direct injections?
Well, you can't do a direct injection into the heart unless
No,
extreme
I
pain.
didn't mean
But
direct.
you would, but for erectile dysfunction, it is a direct injection into the corpus callosum. So it'll be an IV push for heart disease.
Right. Okay.
I
And
will say, having said that, I'm sorry, is it Dr. Krejci?
now just call me Casey.
Okay. Casey, I will say that there is a byproduct that we all sort of chuckle about, and it is perceptibly different in females as well. With the IV push, your blood flow is significantly more, and that
what about
does.
what about NO?
Female.
What about nitric oxide levels?
So yes, we do have a lot of patients come back and say, in fact, this actually does balance out the endocrine system too. So we've had a lot of, let's say, middle or older age gentlemen come back and say that their energy levels are off the charts. As I stated, their wives want them to go and stay at the Holiday Inn.
That's funny. I heard you say that.
And
Have you tested the direct impact on nitric oxide levels generally?
I have not seen any testing on it now.
We haven't done that, not yet. But I can tell you that phenomenon is true. And
Mhm.
if you come to Florida, I'll tell you more. This is not for a public forum discussion.
Right.
or text me.
Couple of beers in. Yeah.
I'll tell you what it does to normals.
What defines a normal?
Well, somebody who doesn't complain of having a problem. But
Oh, okay.
you'd have to come to Miami. Don't want to offend anyone at all.
That's fun. That's funny. Well, I mean, yeah, I was just interested in, particularly in, some of the areas where you're seeing benefit seems to indicate a kick in the nitric oxide levels, and I didn't know if anybody had any experience with that.
I haven't seen any testing, like I said.
Okay. Well, this is fascinating, guys. You guys are just a great panel of experts, and Dr. Shaw, I include you in that. And looking forward to trying it. And Dr. Shaw, when you're down here, when are you coming?
17th and 18th of February.
Okay, beautiful.
2 weeks.
Dr. Johnson, truly a heartfelt thank you. You bring so much to the company, to the learning curve for both our team and the clinicians out in the field, and much respect. I appreciate you taking the time after a long day in the evening and all that you give and sharing as well. So thank you truly, sir. I appreciate it. And
Yeah.
all of the clinicians
Thank
on the
you.
phone, thank you for taking the time to spend your evening with us. Are there any questions that we have not covered that people have?
Well, I particularly say you guys are an A team, and I say God bless you all. Appreciate all you're doing.
Thank you so
Yeah,
much.
thank
Casey.
you. I look forward to coming down and visiting in Miami. And last time when I was down last week in Florida, I was in Port St. Lucie and met with a gentleman who's developing these Alzheimer's treatment centers. And I don't know if he was on the call today or not, but I definitely want to learn more about how to implement this in that context. All the
That sounds great. Well,
neurodegenerative
also for concussion, right?
Yeah.
Absolutely, just any neurodegenerative or brain injury type disease.
How do you inject? How do you use it for concussion with mannitol? Because I think you mentioned that at one point.
If we're doing intrathecal, we do with mannitol, but if we do everything with mannitol, even when we do into littlest area. So we use mannitol.
What's the mannitol protocol for? Is it a pre?
It's usually about 50 to 100 mils of mannitol. You don't want to do too much mannitol because the client will just want to go to the restroom and you won't be able to do your procedure. And then you wait a few minutes and then you do your injection. It's very simple.
It opens the blood-brain barrier for 20 minutes or so, right?
Yeah, it increases the pause. Yes, it does for about, I think 20 is long. I would say like 10 minutes, usually. And that's enough. And you can usually tell when that happens because we inject the mannitol. Because of that, the patients will usually complain of a slight headache.
Okay. Awesome.
All
Again,
right.
you guys, thank you so much, guys.
Yeah, thank you very much for your time.
Thank you, everyone.
God bless you guys.
Dr. Johnson, thank you so much, sir. Much respect and much appreciation. I hope you have a great night, sir. Everyone, have a wonderful night.
You too. Thank you. Bye.